of the patient. Then there are special precautions to be taken. Now we know that it is treatment which involves 3 weeks treatment or the maybe 5 weeks time. So every day, to ensure that position of the patient remains same, it is very, very important, because if there is a small misalignment of the patient on the treatment couch, we will have the same effect as if the couch were angled. So to ensure the position of the patient every day, we have to put 2 tattoos on the anterior abdominal wall, and the ceiling laser light is matched every day on these 2 tattoos. The other, during setup, the other problem may be the rotation of the body while you setting up patient every day. And it will have a great effect on underlying critical organs. What happens that if there is some rotation, say 5-degree rotation of patient, then everything or all the critical organs inside the body will also be rotated, and you see more lung will come in radiation portal. So it is very important that no rotation, setting up of patient every day be there. And to ensure that there is no rotation, we put 2 tattoos laterally on the side of the abdomen, and the side laser is matched with these 2 tattoos every day. So basically you use 4 tattoos, 2 tattoos on the anterior abdominal wall, 2 tattoos laterally, to ensure that the position of the patient remains same every day and it doesn't change. Now the next is that what are the regions which we need to treat after modified radical mastectomy or maybe after lumpectomy. Now in breast cancer, there are multiple regions which may require radiation, and these all are adjacent regions, because we want to treat the local disease as well as regional disease depending upon the stage of the disease. So what are the various regions? Now regions are: 1, supraclavicular; 2, axilla; 3, internal mammary group of lymph node; and finally the chest wall or the intact breast after lumpectomy. Now supraclavicular region is usually treated by a direct field. Axilla is also treated by direct field. Internal mammary either treated with direct field, or if it is included with chest wall irradiation, then we treat internal mammary group of lymph node by tangential portals. Chest wall is always treated by tangential portals. So what are the difficulties in radiation delivery? What are the difficulties in radiation deliveries? And most of the problem are because of adjacent portals which are there to treat different regions. So actually there are 3 main issues when we plan radiation for breast cancer. One is matching of the adjacent radiation field. As I said, that there are multiple regions which need to be treated, like supraclavicular, internal mammary, chest wall. So there is, the junction between these 2 fields. And the problem arises mainly because of divergent nature of the radiation beam, because we know that as radiation emits out from the point source, it is divergent in nature. So if you treat one region, say one of the area with 200 centigrade, the other adjacent area with another 200 centigrade. So if you match the field at the surface of patient or patient body surface, then you will appreciate that beneath the surface, you will have a hot spot. Am I audible?
Yes, sir.
Okay. So beneath the surface, you see that the region will receive 200 centigrade from this field, 200 centigrade from other field, resulting into formation of a hot spot. Or if you match the field beneath the surface, then the sum of the tissue which is lying at the matching line or at the junction will receive less dose of radiation, and it will form a cold spot. So that is the problem, and how to tackle this problem I will discuss in subsequent slides. The other problem of radiation treatment of breast is sloping chest wall. We know that chest wall is sloping. There are two slopes. One is craniocaudal slope. The other is mediolateral slope. So because of this slope, there are issues which I will discuss in subsequent slides. The third problem is critical organs are just beneath the area of interest or beneath the target area. And these critical organs are mainly lung and the heart. So how to save lung and heart is another issue which I will discuss. So there are three mainly difficulties or three main problems in planning of breast cancer by radiation. So we'll discuss one by one. Let us first look at matching of the adjacent radiation field. So there are basically two divergences. If you see, first let us look at the junction between supraclavicular and chest wall. If we include axilla also, so it becomes supraclavicular plus axillary field and chest wall. Can you unmute? I will request participant to unmute, please. So there are two divergences if you see. One is divergence from supraclavicular axillary field. Other is divergence from chest wall tangential portals. So what happens if you look at the supraclavicular portal, a supraclavicular field, this is the breast portal. So when you see at the supraclavicular field, you will see that because of divergent nature, it will encroach the breast portals, and this result into hot spot formation at the junction. From tangential portal, again, if you look at the tangential portal, medial and lateral tangential portal, again, you see it is encroaching into the supraclavicular field, and this further result into hot spot formation at the junction. So how to sort out this problem? Now let us first look at what are the solutions which can be utilized to counter the divergence from supraclavicular portal. First is half beam block. So what we do, we first set the central axis of the beam at matching line, and then we open double the length of the field. For example, if the length of supraclavicular field is 6 centimeter, we open 12 centimeter, and the lower half of the field is blocked. And now you can see that there is a sharp edge rather than divergent nature. There is a sharp edge nicely matching with breast portals. Second, if machines are having asymmetrical jaw, as most of you are working on lean neck, so every lean neck usually have asymmetrical jaws. So if you have asymmetrical jaws, the same work can be done with asymmetrical jaw as well. So again, you set the central axis at the junction and open double the length, but lower jaw is usually closed. It don't open the lower jaw, only we open the upper jaw. And again, you see there is a very sharp line matching with breast portals. Now, some of you must be working only with Cobalt. You don't have, the asymmetrical jaw. You don't have even the shielding material because many centers, which are at remote place will just have a very basic Cobalt machine. So what you can do to match the supraclavicular field with breast portal, still you can match it by just calculating the angle of divergence from supraclavicular field. So the question is that how we calculate angle of divergence from supraclavicular field. It is very simple. The angle of divergence is the angle which the lateral edge of the beam form with the central axis. So this is the angle of divergence, and it can be obtained from a formula that is tan theta is equal to half field length divided by SSD. So suppose the length of supraclavicular field is 6 centimeter, then half field length is 3 centimeter, and SSD usually for Cobalt is 80 centimeter, but if you are working on lean neck, it is 100 centimeter. So putting these value here, you can get the angle of divergence by this formula. Suppose this angle of divergence comes out to be 6 degree, then what is to be done? Now you move couch by 90 degree and then rotate gantry 6 degree towards patient feet. Now the direction of rotation of gantry is very important, that you have to rotate the gantry towards feet, not towards face of patient. Now let me make it more clear with this picture. Now this is suppose couch, this is the gantry. So first you move couch to 90 degree. So you move the couch to 90 degree, and now if you just start the machine, you will see the divergent nature of the radiation beam. And let me put a patient here. So you see the divergent nature of the radiation beam, but then you have calculated the 6-degree movement of the gantry towards patient feet. So you move the gantry towards patient feet, and once you move the gantry by that angle towards patient feet, and now you can appreciate that the lower edge of the beam become a straight line. It is no more divergent, and you will appreciate that it will just match with breast portals very nicely. So even if you don't have any accessories, just by calculating the divergence angle, you can very well match the supraclavicular field with breast portals. Now, let me just show again on machine actually. So this is a Cobalt 60 machine. So what we have to do, first we have to give the couch rotation by 90 degree. So I have just rotated the couch by 90 degree. And suppose there is a patient. Now, if at the 0-degree gantry, you just irradiate, you will see the divergent nature of the beam. And naturally, it will encroach to the breast portals and it will create a hot spot here. But we have calculated the angle of divergence and we have to move the gantry towards patient feet. I am again emphasizing that gantry should be moved towards patient feet. So now when you move the gantry towards patient feet, now you will appreciate that lower edge of the beam becomes just a straight line. There is no more divergence and it will very nicely match with breast portals. So these are the three methods by which we can counter or we can sort out the problem of divergence from supraclavicular field. Now, similarly, the divergence is also there from breast chest wall tangential portals. So again, the solution is same what we have seen in previous slides. One is that if you have asymmetrical jaw, then you open double the length. First set the center of the beam at the junction and open the double the length of the breast field and just open only the the lower jaw. The cranial jaw is closed, and again you can see that instead of divergence nature, now you have a central center of the beam which is a straight line, and how nicely it is matching with supraclavicular portal. If you don't have asymmetrical jaw, as I said, many of you are working on Cobalt machine only, then again you can sort out this problem by couch rotation. So in couch rotation, again you calculate the angle of divergence. And as I said, the calculation is very simple. This is the angle of divergence. And the formula for this is half field length divided by SSD. Suppose the length of the chest wall field is 16 centimeter. So half field length is 8 centimeter. SSD in case of Cobalt is 80 centimeter. For LINAC, it is 100 centimeter. Put this value here and you can find out the tan theta. Now let us presume again that it is 6 degrees. So what is to be done next? Now next you have to do, set the tangential field as usual, what you have planned. Now give couch a 6-degree twist away from gantry in both medial tangential and in lateral tangential portal. Now how it is to be done? Again with this picture it will be more clear. So this is the normal position of the couch, and suppose this is the gantry angle, and if you don't give any twist to the couch, then you can see the divergence of the beam. But if you give twist to the couch 6 degree away from gantry, then you will appreciate that upper edge of the field will become a straight line in reference to the long axis of the table of or long axis of the couch. Similarly, from the other side also, again you give 6-degree twist depending what angle you want to give. Again you give the twist, and again you but again remember that twist has to be given away from the gantry, and again you will appreciate that upper border of the field becomes a straight line in reference to long axis of the couch. So if this is a supraclavicular field, and these are the medial and lateral tangential without any couch twist, they will encroach to supraclavicular region. But when you give a couch twist, the upper border becomes a straight line from both medial tangential as well as from lateral tangential portals, and it is very nicely matched with supraclavicular field. So that is how we can sort out the problem of divergence in matching the supraclavicular field with tangential portals. And on patient, when you give couch twist, it will be something like this. It will look on patient surface something like this. Now the next is the junction between internal mammary lymph node and the tangential portals. So if you take a axial cut of the center of the portals in the chest wall or in the intact breast, now this is the central axis of the tangential portals or the medial tangential portals, and this is the direct internal mammary portal. Now you will appreciate that at junction, if they are matched at surface, then beneath the surface, you will see that this triangle, there will be a cold spot. So if both fields are matched as the surface, then this inside the body, you will see this triangle, which is a cold area or cold spot. And usually the internal mammary lymph node is present in this region. So naturally, the internal mammary lymph node will not be receiving the adequate radiation dose. So why there is a cold area when you treat, when you match at the junction? Because the two fields are angled in different direction. So this is angled in this direction, this field is angled in this direction. And that is the reason that the cold area is formed. So what is the solution? Now solution is simple, that you also angle the internal mammary field so that it becomes parallel to tangential portals. So internal mammary field, instead of having a straight at 0-degree gantry, you have to give an angle which will make it parallel to tangential portals. So that will sort out the problem of cold spot here. But then another problem crops up. What is that problem? That this beam will now pass through the lung. So more lung will be irradiated, resulting into a lot of complication. So how to sort out this problem? What is the solution? Now solution is very simple. We have to use radiation which have limited penetrating power. And we all know the radiation which have limited penetrating power. What is that? That is electron beam. So internal mammary field should be treated with electron beam so that underlying lung tissue can be spared. So solution is very simple. Angle the internal mammary field, make it parallel to the tangential portal, and use electron beam instead of photon beam. So these were basically few of the problem of the matching and how to overcome these problems. I hope that now all of you understand how to cope up with all these problems. Now the another problem of chest wall irradiation or the breast irradiation is because of sloping chest wall. So what is exactly problem because of sloping chest wall? Now our aim of treating the primary tumor bed is that we want to deliver adequate dose to the chest wall. So if you cover adequately the chest wall, then you will appreciate that lung at caudal and will be receiving more doses, and more volume of the lung is coming at caudal end, and it will result into more volume of the lung irradiation, resulting into complication. Or if you just reduce the volume of the lung at caudal end, then you will see that some of the deeper tissue or the portion of the chest wall will not receive adequate dose of radiation. So that is the problem. Now, how to solve this problem? Very simple. All of us are using, every day in solving this problem. So the solution is very simple. Use a breastboard. So when you use a breastboard, it will make the anterior chest wall as well as anterior border of the lung parallel to the couch. And now if you put a chest wall field, you will appreciate that there will not be any more volume of the lung caudally. From cranial to caudal, the volume of the lung will almost same. So that is one advantage of using breastbone. If you don't working in a very primitive center where there is just a Cobalt machine, you don't have a breastbone, then how to solve this problem? Again, you can solve this problem by giving a collimator angle, right? So give an angle to collimator so that the posterior border of the field becomes parallel to anterior border of the lung. And this way you can reduce the volume of lung caudally, which will receive radiation. But then you can say, or you can see that this, when you give collimator angle, then some of the portion will be encroaching into supraclavicular region and it will create a hot spot again. So naturally that will certainly be there. But again, if you are working in a good center, you have facility to cast individualized block, then what you can do, this portion you can shield by casting individualized block so that there is no hot spot. If you don't have facility, then naturally we will have to compromise with this hot spot. But certainly this hot spot will be at the soft tissue. But if you don't give collimator angle, then lung is more critical for us. So more volume of the lung will receive radiation. Another solution, if you don't have a breastbone, but you have facility to cast individualized block, then you can cast an individualized block of lung so that the lung can be, the excess volume of the lung can be shielded. So this is again the third solution by which you can reduce the volume of the lung which will receive radiation. So that was the second issue. Then third issue is underlying heart and lung. Now we know that these two critical structures are just beneath the target. So naturally we have to treat target, but naturally we have to save these critical organs. So what happens if you look at the tangential portals, right? If you look at the tangential portals, now because of divergent nature of the beam, right? If there you see that lot of lung volume is coming in the radiation portals. So what is the solution? Now solution is again very simple and all of you are using on day-to-day basis. What you do, you use breast cone. So you set the central axis at the entry point of medial and lateral tangential field and open double the width of the field. So you open double the width of the field, but the deeper portion you shield it by using breast cone. So you can see there is a sharp edge now, posterior border of the field cutting through the lung and less volume of the lung is coming into the field. If you have asymmetrical jaws, the same can be done with asymmetrical jaw as well. Again, you set the central axis at the entry point, open double the width of the field, but only open one jaw. That is the superior or the external jaw is open, the deeper jaw is closed. So the same thing can be done by using asymmetrical jaw, and you can reduce the volume of the lung receiving radiation. If you don't have asymmetrical jaw, if you don't have breast cone, you're working in a very primitive center, still you can save lung. And the solution is you rotate gantry head upward. So how does it work? Just try to understand. Now, if you don't rotate the gantry head, then because of divergent nature, lot of lung volume is coming into the radiation field. But if when you move the gantry up, the lower edge of the field becomes a straight line. And now it will be a sharp straight line which will be passing through the lung, and volume of the lung receiving radiation will also be less. And again, the question is, what degree of the rotation we should give? Answer is same. You can calculate the degree of rotation or the angle of rotation by this formula, tan theta is equal to half field width divided by SST. So this is the third method by which you can save your lung. Now on gantry, how we do, just try to understand, just to make the things more clear. Now suppose this is the lateral, the lateral tangential portal. Without any gantry twist, you will see the divergent nature of the beam. But when you twist the gantry upward, you will appreciate that lower border will become a straight line. So that way we can save the lung. Again, on an axial cut, you can see that when you twist the gantry upward direction, the lower border become a straight line. So you can do the same thing just by rotating the gantry in upward direction, what you achieve with using breast cone or with asymmetrical jaw. So these are the three methods by which you can reduce the volume of the lung receiving radiation. So these were the various problems which, I discussed just now. Three main problems. One, because of the matching of the field. Second, because of underlying critical organs. And third, because of sloping chest wall. Now coming on to the second aspect of radiation planning, that is number of field. How many field we should use? There are two techniques mainly. One is two field technique. The other is three field technique. Now let us look at two field technique. Now in two field technique, we use supraclavicular and axilla in a single field, and internal memory and chest wall in tangential portal. So when you include the internal memory in tangential portal, naturally the medial border has to be extended on opposite side by at least 2 centimeters. Otherwise, if you only twist chest wall, then medial border is kept at midline. So what is the problem if you include the internal memory in tangential portal? Now, if you just treat the chest wall, these are the entry point of medial tangential and lateral tangential portal. That is mainly at the midline. So if the central axis passing through the midline or through the this entry portion, then the internal memory group of lymph node, which is located somewhere here, will not be treated. But if you want to include internal memory group of lymph node, naturally the entry point of medial tangential portal will be shifted towards opposite side. So now it has to be here almost 2 to 3 centimeter from midline in opposite breast. So when now the central axis passes through this entry, now we can deliver adequate dose to internal memory lymph node. But at the same time, you see more lung is being irradiated now. Not only the lung, but the opposite breast will also receive higher dose of radiation. And third, the underlying heart will also receive radiation doses, which otherwise can be avoided if you don't include internal memory lymph node in tangential portals. So these are the drawbacks when you include the internal memory group of lymph node in tangential portals. So what is the solution? Now solution came from the biology of the breast cancer. Now it was observed that not all the internal memory group of lymph nodes which are present along the internal memory artery are involved by breast cancer. It was seen clinically that only lymph node of upper 3 intercostal space are involved. So we use a deep tangential or extended partial tangential field. Now in this, only the upper 3 intercostal area, the medial border of the tangential portal is extended towards opposite side. The rest of the tangential portal remain at midline, so that only the upper 3 intercostal space are irradiated. The lower space don't receive any radiation. And it looks something on simulator film like this, that you are including only internal memory lymph node of upper 3 intercostal space, and lower down you have shielded the lung. So that is how we can use the extended partial tangential portal to reduce the dose to the lung. In three-field technique, we use supraclavicular and axilla by direct field, internal memory by separate field, and chest wall tangential field separately. So, but as I already discussed, that when you use internal memory separately, what are the issues? Like there will be a cold spot, then you have to angle the internal memory portals also, but then it will be more dose to the lung. So use electron beam, angled electron beam for internal memory portals. Now coming on to field boundaries, right? Indication, as I said, I will not go into debate. There may be some debatable, indication, but the absolute indication of supraclavicular radiotherapy is more than four axillary lymph node, T3 or T4 tumors, inadequate axillary dissection, no axillary dissection. So what are the field boundaries? Again, you can find out in any standard book, but let me just give you some idea. The lower border of supraclavicular field is matched at upper border of tangential field. The lateral border the upper border is at thyrocricoid groove. The lateral border, you identify the cricoid process, and the lateral border is kept lateral to cricoid process. And medial border, you identify the sternocleidomastoid muscle, and medial border just run at the medial edge of the sternocleidomastoid muscle. Portals, direct anterior, single portal. Prescription depth is 3 centimeter from skin. Beam, as I said, either photon, 4 to 6 MeV, or simple cobalt. Now, the chest wall irradiation or the breast cancer is one side where we always prefer low energy radiation over high energy radiation. So we will always prefer a 4 MeV or 6 MeV or cobalt 60 over a 15 MeV beam. Coming on to radiotherapy to axilla, indication if there is an inadequate axillary dissection, and we all considered that any number less than 10 is considered as inadequate axillary dissection. No axillary dissection in presence of positive sentinel node, extensive extracapsular extension, and more than 75% nodes are positive. Boundaries remains the same as supraclavicular field. Only difference is that lateral portion is further extended laterally to cover the axilla. But then you see one critical important structure comes into the portal, that is the head of the humerus. So you have to shield the head of the humerus. So it will look something like this on patient surface. So it includes axilla, but shielding the head of humerus. Similarly, you can see on simulation picture that it is including axilla, but at the same time, we are shielding the head of humerus. When you treat axilla by supraclavicular field, extending it laterally to include axilla, the one issue crop up. What is the issue? Basically, for supraclavicular field, we calculate the dose at a depth of 3 centimeter, right? But the axillary lymph node present deeper to supraclavicular lymph node. So naturally depth is much more, and sometimes it is at the mid plane. So naturally when you calculate the dose at 3 centimeter, less dose will be delivered to axilla. So if you calculate 50 gray at 3 centimeter, naturally the axillary group of lymph nodes are going to receive less than 50 gray. So to compensate that dose, we have to put another portals in the axilla, which is called posterior axillary field. So you have to add posterior axillary field to bring the dose to 50 gray. Now these are the boundaries of posterior axillary field. These are very standard boundaries you can find from any standard book. So just I will not read all these things. But the important point is that how to calculate that how much dose to be delivered from posterior axillary field. Now again, it is very simple. You calculate the contribution at mid-plane by supraclavicular and axillary field, and rest of the doses which are just to make it 50 gray to be delivered by posterior field. For example, if the contribution from anterior field is 35 gray, then 15 gray you have to deliver from posterior field with a dose per fraction, say 1.8 to 2 gray. Now coming on to internal memory port lymph node. Now, if you look at the incidence of internal memory lymph node involvement, it depends upon location of the primary tumor as well as axillary lymph node status. Now, if the primary tumor is present medially, then there are 15% chances of internal memory group of lymph node involvement. But if it is associated with extensive axillary disease, then chances of lymph node involvement increases from 15% to 50% if the tumor is in medial portion, or sorry, in the central portion with axillary group of lymph node involvement, then there are 40% incidence or chances of internal memory lymph node metastasis, or if it is present in the outer surface with axillary group of lymph node, then probability of internal memory lymph node involvement is 20%. So the indication of internal memory lymph node irradiations are when there is extensive axillary disease or when there is central or median tumor more than 5 centimeter in size. Now, if you look at the location of internal memory lymph nodes, they are in close proximity to the internal memory vessels, somewhere here, which is 3 to 4 centimeter from midline and 3 to 4 centimeter from surface. So if you look at the field boundaries, the medial boundary is at the midline and upper boundary at the lower boundary of the supraclavicular field. And we take a width of usually 5 centimeter, and lower boundary is kept at 4th costal cartilage. As I mentioned, that only lymph node of upper 3 intercostal space are involved most commonly. So we don't treat whole internal memory or whole sternum or whole internal memory lymph nodes, which we used to treat in past when we used to keep the lower border at the base of GP sternum or at the base of G5, but now we no more treat the whole internal memory group of lymph node. We just keep the lower border at the 4th intercostal space. Depth of 4 centimeter we prescribe, and again we treat with usually with electron, not, and again angled beam we have to use. Now coming on to the chest wall irradiation. Now this is treated by 2 tangential field. We all know medial and lateral tangential. Now if you look at the field boundary, the upper border is kept at sternal head of the clavicular. The lower border is kept at 2 centimeter below inframammary fold. And if patient is being treated after MRM, then naturally we take the help of opposite breast to find out the level of inframammary fold, and we keep 2 centimeter below that inframammary fold. The lateral boundary is at mid-axillary line and the medial boundary is at midline. But if you want to include, or if you have treated the internal memory lymph node by a separate field, then medial boundary will be at the lateral boundary of internal memory field. Or if you want to include internal memory lymph node in tangential portal, then the boundary, medial boundary of tangential portal will be 2 centimeter towards opposite side. So depending upon whether you are treating internal memory lymph node, if no, then at the midline. If you are treating internal memory lymph node, if treated by separate field, then at the medial or the lateral boundary of the internal memory lymph node. Or if you are including the internal memory lymph node in the tangential portal, then 2 centimeter towards opposite side. Again, energy is cobalt 60 or 4 to 6 MeV photon. Now, when you prescribe any, portal, when you write down the prescription for any portal, you need length and width of the radiation field. And in tangential portal, you also need gantry angle. You have to specify gantry angle through which the radiation will be fired. So how we are going to get all these parameters? Now length, you can find out from the patient surface. So that is the length of the tangential portal. But how to find out the width and gantry of angle? Again, this is very important for all the, residents, especially the JR, how to calculate the width and the gantry angle for tangential portals. Now it is very simple. You take the contour from the center of this uh, radiation beam, or from the center of this field, and draw on a plane sheet, uh, mark the entry point of medial tangential and the lateral tangential. I'm pretty sure that all of you can take the contour on patient surface. All of you must have learned how to take contour of, from patient, and how to mark it on a plane sheet. And you also mark the entry point of medial tangential and lateral tangential, and just join these 2 points like this, and you will get the gantry angle. So this is the gantry angle for medial tangential, and this is the gantry angle for lateral tangential. So it is very simple. You can find out, you can calculate the individualized gantry angle for every patient you are treating on machine, if you don't have simulation, or if you don't have facility of simulation. So just by taking a contour, you can find out the gantry angle. Now regarding the width of the field, again, it is now very simple. At the center, you take, this is the width of the field, right? So from this line up to the highest point where the soft tissue is there, you take this, you measure that length, add 1 centimeter of air portion into it, and that will give you width of the field. If you just superimpose an axial section through that, through the middle of the field of tangential field, you will see the relationship with lung and the chest wall. So you can very well see that whole of the chest wall is included, and some of the lung is also included. Now this is very important. We deliberately include some portion of the lung. Now why it is important? 2 reasons. One is that there is a movement of the chest wall, right? So that has to be taken into account. So this basically to cover the PTV, which also include the movement of chest wall. So that the posterior most portion of the chest wall can receive adequate dose of radiation, right? And so that is the main reason why we take, some of the lung. And the question is that how much lung, how much width of the lung is acceptable. Now it is usually considered that not 2 centimeter, more than 2 centimeter of the lung should be included in tangential portal. And as I said, that upper border should be 1 centimeter in air. So tangential portal will look something like this on simulation. If you see on DRR, this is a DRR, and on patient surface. So this will look something like this. Now coming on to another important point of tangential portal, and again it is very commonly asked in examination, that if you look at the dose distribution, if you are treating an intact breast, and if you look at the dose distribution, you will observe that there is a hot spot at 3 points. One at the surface, near the surface, and 2 at the medial and lateral portion of the breast tissue. So there are 3 hot spots you see. You planned 5,000, but the surface is receiving 6,000 and this portion also receiving, you know, around 5,500. So there are 3 points where the hot spots are formed. Now, why at these 3 points the hot spots are formed? Now, just again try to understand. We know we understand why there is a hot spot at surface, because we know that there is a missing tissue here and the radiation is passing through air which has got less attenuating power as the soft tissue. So naturally more dose is reaching to this point, and that is the reason that you get a hot spot at surface. But what is the reason that hot spots are also formed at medial and the lateral breast tissue? Again, just try to understand. Now, this is the entry point of medial and lateral tangential portals. Now, let us just assume a single beam, a single pencil beam. So this pencil beam is passing through this, second, third, and now fourth beam. So now you see, now these 3 beams are passing through lung. And to, you know, tissue missing here, now lung we know also attenuate less than the soft tissue. So naturally these 3 beams will be contributing more dose to this region. Similarly, the 3 beams which are passing or which are coming from lateral tangential portal will be contributing more dose at this point. So you will get the hot spot at medial portion of the breast tissue and lateral portion of the breast tissue. And beyond this, all the beams, they are passing through only the tissue, not through the lung. But as I said again, that at the surface, because of the curvature, there are missing tissue. So naturally, the anterior portion of the breast is also going to receive higher doses, creating a hot spot here. Now, how we can avoid these hot spot can be avoided by using the breast con. And I think most of us are practicing this. So anterior portion hot spot can be avoided by using breast con, but medial and lateral portion, probably we don't have any method by which we can avoid, except yes, probably with IMRT, we can make the dose distribution more uniform and we can avoid hot spot at medial and lateral portion of the breast. But if you don't have IMRT with 3D conformer, probably we don't have any method or any technique by which we can avoid the hot spot. This is my last slide. Just few, definition which residents should understand and learn. One is central lung distance. So it is basically the width of the lung at central axis. So this is the width of the lung at the central axis, which comes into the radiation portal. Then lung length, sorry, this is the CLDS. So width of the lung, this is the width of the lung, which at the central axis. So this is the central lung distance. The lung length is the vertical lung distance, which is included in the radiation portal. So this is the lung length. You see, this is the lung length, which is coming in the radiation portals. And then maximum heart distance, it is the width of the heart in the tangential field. So it has nothing to do with the central axis, but the maximum width of the heart, wherever it comes in the radiation portal, that is taken as maximum heart distance. And then maximum heart length, it is the maximum length of the heart, which is coming into the radiation portal. So this is the maximum radiation portal. So these definition again may be asked in examination. So you need to understand and learn these definition. So with this, I think I finished my presentation. So I hope I could do justice to my topic, and I presume that now all of you can plan radiotherapy in breast cancer, even if you don't have HIFI radiation equipment like CT SIM or the conventional SIM, but still with manual planning, you can do a very good job. If there is any question, please let me know. Navneet, over to
Yes.
you. So,
Thank you so much, sir. It was really a wonderful talk. And we are all very much grateful to you for taking this class, sir.
I think there are some questions. Two participants raised hand. So can we have question?
Thank you, sir, for such a nice presentation. Sir, I have a question regarding the posterior axillary boost. Since in most of the books we studied that posterior axillary boost is obsolete now and is not practiced in renal routine. So how do we ensure the coverage of the axillary lymph nodes from the anterior field itself?
It is not possible. Let me tell you, books may write anything. You know, it is not possible to if you are treating with intensity modulation radiotherapy, then it is fine. You can do with that. But with 3D conformal radiotherapy or with 2D radiotherapy, it is not possible. As you yourself have seen, the location of axillary lymph node is much deeper than supraclavicular lymph node. So if you calculate, say, at the depth of axillary lymph node, then you will be delivering higher dose superficially to the normal structure. So usually we calculate at 3 centimeter depth, and if you calculate at 3 centimeter depth, we will not be delivering 50 gray to axillary group of lymph node. But of course, if you are planning, if you are treating with IMRT, then certainly there is no role of posterior axillary boost.
Okay, sir. Thank you.
Thank you, sir.
So can I leave now, Navneet, if there is no more question?
Actually, we are really thankful, sir. We are on the behalf of everyone, I take this opportunity to thank you. And we would like to have more classes from you, sir, in future.
Sure. Welcome. Thank you very much.
Thank you. Thank you.